and we are starting ahead of schedule. So, hi, good afternoon, everyone. If you could just give us a moment, we'll be starting in just a minute.
Hello, everyone. Sorry for the false start, but we are ready to get going. Thank you for joining today's webinar, Lessons Learned from COVID-19 and Other Emergencies. I am Catherine Martucci, Director of Policy and Programs at the Alliance for Health Policy, And for those of you who are not familiar with the Alliance, we are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. And we gratefully acknowledge the Commonwealth Fund for supporting today's webinar. And I also want to remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive, and join our community at All Health Policy, as well as on Facebook and LinkedIn. And we also want you to be active participants in today's discussion, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time, and we'll be collecting these and addressing them throughout the broadcast. And you can also chat any technical issues you may be experiencing, and someone will attempt to help. And then finally, please be sure to check out our website, allhealthpolicy.org, where you can find background materials on today's session, including a resource list and an expert list. And then we will also be including a recording of today's webinar and the slide deck as well. So now I am pleased to introduce our moderator for today's briefing. Mr. Reginald D. Williams II is Vice President of International Health Policy and Practice Innovations, Commonwealth Fund. In this role, he is responsible for fostering international dialogue, exchange, and education that enables U.S. policymakers and healthcare leaders to learn from cross-national experiences. Reggie is also responsible for the Commonwealth Fund's international benchmarking activities, its international research and policy analysis, and the educational exchanges it conducts with key international partners. So we are very excited to have him today to lead this conversation, and I will turn it over to Reggie.
Well, thank you for that warm introduction, Catherine. COVID-19 is officially the deadliest outbreak in recent American history, surpassing the estimated fatalities from the 1918 influenza pandemic. This death toll means that roughly 1 in 500 Americans have died from coronavirus, and this winter may very well bring a new surge. Last week, world leaders gathered at the United Nations General Assembly, and President Biden held a summit to call on global leaders to make a new worldwide commitment to bring an end to the pandemic and to fight future pandemics. Last week, the Commonwealth Fund also released a new report that shows how proactive investment in public health and healthcare delivery can help develop the resiliency needed to meet the challenges posed not only by disease pandemics, but by other emergencies like hurricanes, flooding, and wildfire. Today, we have a brief opportunity to pause and reflect and grapple with topics like staffing our healthcare facilities, general access to care, decision-making and triage, data infrastructure, and communications for pandemic preparedness and response and dealing with other emergencies. We are excited to have panelists with us today to explore these and other important topics from both the international and domestic perspective. And each one of the individuals here has had an opportunity to really engage with people that have been working on the front lines of the pandemic inside and outside of the US to bring forward perspective that we all can learn from a policy and research standpoint. So now I'd like to introduce today's panelists. Here with me today to further explore the lessons learned from COVID-19 are 3 experts. The first we have is Dylan Scott. Dylan is a senior correspondent at Vox. His reporting primarily focuses on healthcare and other domestic policy issues. And Dylan has been a great partner to the Commonwealth Fund and doing work that really looks internationally at the experience of delivering care and reporting back to people in the US on what it's like to be in other countries. Prior to joining Vox, he worked as Washington correspondent for Stat News, and he was a reporter at the National Journal. Next, I'm pleased to introduce Carolyn Pearson, who's going to join us today. Caroline is Senior Vice President at NORC at the University of Chicago, where she leads the Healthcare Strategy Group and provides research, data analysis, and policy support to a wide range of organizations. And I can also say Caroline is a former colleague and a good friend. And finally, we have Dr. Rebecca Wintrob, who's the Director of Better Evidence in COVID-19 Vaccine Delivery and Assistant Professor in the Department of Global Health and Social Medicine at the Harvard Medical School. She is also an Associate Physician in the Division of Health Equity at Brigham and Women's Hospital, and she's a practicing internist. She's also been a great partner who's been focused on really understanding the experience of working in the hospital and primary care and delivering vaccines to people in need right now. So we're going to launch today's discussion by first hearing from Dylan, who will provide a high-level overview of how other nations have responded to COVID-19. Dylan, I'd like to invite you now to speak. Please turn your mic and camera on. Thank you.
Oh, apologies. Hi, everybody. Thanks for taking the time to be here. And thank you for having me. So as Reggie alluded to, about a year ago, my colleagues and I started looking at pandemic responses around the world. And we wanted to, we were after the same objective as this panel, which was trying to figure out, what were some of the lessons that we could learn from other countries that had excelled in particular parts of their response to COVID-19. So rather than try to capture, the totality of any given country's experience with COVID, we decided to focus on specific parts of their response and how they excelled and how those strategies actually held up over time as the pandemic dragged on. So, for example, we looked at South Korea and their program for testing and tracing and isolating potential COVID contacts that they were able to set up very quickly in the first few weeks of the pandemic. We looked at Vietnam and how they used border closures to try to manage the crisis. And we also looked at the United Kingdom, which in general, obviously, has not really been a COVID success story, but their recovery trial program run through the UK's National Health Service has been very effective at identifying existing drugs that could be useful in trying to treat people with COVID-19. And so beyond the particulars of those stories, I had two big takeaways from our reporting. One was that the ability to act quickly and decisively was paramount to crushing that first wave of COVID. And the countries that were best positioned to do that were countries that had had recent traumatic experiences with infectious disease and had built up the capabilities to combat the next outbreak. So South Korea, for example, had struggled with MERS in 2015, and they introduced a whole slew of public health reforms after that gave the government more authority and more resources to set up the kind of testing, tracing, and isolating program that they were able to quickly implement once COVID arrived. Likewise, Senegal, which was another country that we wrote about, particularly with an eye towards their health system's capacity, had recently struggled with Ebola. And so the first thing that they did once COVID arrived in their country was implement some of the protocols that they had still, laying around from the COVID crisis of a few years ago. So that was one. Second, what was obvious as we reported this series over the course of several months was that the story of the pandemic was constantly changing. Germany at first looked like a success story when we started reporting on it. They had this evidence-based communication campaign that had built support for wearing masks and other social distancing measures. But over the course of the pandemic, the solidarity that communications campaign had built up started to falter. Some of the country's internal politics, which also obviously reached a climax here in the last week, started to get in the way, and instead Germany became a cautionary tale of how a country could lose control of the virus when the solidarity and support for some of those public health interventions starts to wane. And we saw similar stories in Senegal and South Korea as well. And on the flip side of that, the United States, we'd always wanted to do a story about economic relief and the ability to manage the economic crisis that accompanied COVID. And we found that over the course of the 6 to 9 months that we worked on this project, it turned out the U.S. was actually the country arguably with the strongest economic response, which was not something that we had necessarily expected going into it, or that had even been true when we started reporting out this project. So that was another way that the story of the pandemic was constantly evolving underneath our feet. And I think, the other thing that I have been reflecting on in terms of lesson learned from COVID is that this has continued to be true. Our project published in the late spring, just at the time that the vaccination drive was really becoming the dominant storyline. And so some of the countries that we profiled that had really successful early interventions with COVID have since struggled with their vaccine campaigns. South Korea, for example, still trails the U.S. in the percentage of its population that is vaccinated, and they are currently seeing case levels that, while still much lower than what we're seeing here in the U.S., are higher than the countries have experienced before. And likewise, I wrote a story in December about Australia and their program for managing and loosening or strengthening lockdowns depending on case levels. At that time, they seemed like a success story for how those kinds of social distancing measures could be implemented with a kind of clear pathway towards getting to zero COVID. And something that we found, I think Australia has discovered in the months since I wrote that story, the limitations of those strategies. And they're struggling now to get a sufficient percentage of their population vaccinated. And so, that has applied to the U.S. as well. The U.S. obviously started out as a leader in the vaccine drive worldwide and has since flipped to become, much more mediocre in how we stack up to other countries. And, I did a story recently on Portugal, which has since surpassed the United States in its vaccination campaign and actually ranks at the top among European countries. And something I found that was interesting in talking to a Portuguese expert about why their country had proven so successful is there were two things that stood out to him. One was this kind of cultural factor. Portuguese, as some of you may know, lived under a military dictatorship until the 1970s, and it was only with that more recent liberalization that vaccines were widely available and most people got them. And so there was a different kind of appreciation among the Portuguese for what vaccines can do, maybe compared to a country with a longer period of a more liberalized society like the United States. And the other part of it was that, Portugal had a very centralized program for administering and distributing its vaccines that had probably been helpful as well. And that kind of twofold takeaway is really where I've been left here, sitting here in September 2021, thinking about how we learn from what's happened over the last 18 months. On the one hand, there are intrinsic things, cultural and social factors that will be really hard to change and that will always have an influence on how we are able to respond to something like the pandemic. But on the other hand, there are programmatic things, policy changes that could potentially be made that would have us be better prepared, the next time something like this happens. I think the examples of South Korea and Senegal speak to that ability to learn from the lessons of the past. And so my question now, which, the other panelists and maybe even the audience might be better equipped to answer is whether we will actually learn how much have we really learned from the COVID pandemic and our failures, and how much better prepared will we be next time? That's what I'm going to be watching going forward.
Well, thank you for that helpful context, Dylan. And now I would like to invite Caroline to speak a little bit about the work she's been doing. Caroline, you're on.
Hi, thank you so much. So I wanted to talk a little bit about some of the research that we have done and published recently with support from the Commonwealth Fund. Again, similar to Dylan, really looking at some of the lessons learned that we can find from international delivery systems. Now, our research was really specifically focused on delivery systems and the provision of healthcare and how that health system operates. We were not focused on the public health response, including things like mask mandates and lockdowns, given how much emphasis and attention that got from other coverage. But I think similar to Dylan, one of the things that really struck me in our research is just how important those public health measures were in terms of enabling providers, hospitals, and the rest of the healthcare system to actually operate effectively during the pandemic. Clearly, countries that responded quickly and were able to flatten that curve and slow their case rate took a lot of pressure off of the delivery system. And so that was very helpful, especially early on in the pandemic. We talked with people in the United States who were on the ground trying to manage delivery system response, and we identified sort of 5 key areas of focus. The first was staffing. In the United States, we struggled mightily with maintaining adequate staffing during COVID-19 surges. Folks were worried about, when we did our research, stress and burnout among staff, and we have certainly heard that come to be a huge issue as the pandemic has worn on. We were focused on access to care, and so, how does the delivery system pivot in order to continue to provide ongoing regular care in addition to delivering COVID-19 care and treatment as needed? Our third big topic was decision making. And one of the things that we really saw as a challenge in the United States was because of our pretty federalist nature, we had sort of limited leadership at the federal level, but a lot of decisions were really left to state governments. We saw a huge growth in the role of governors during the pandemic, as well as sort of city mayors and frankly health system leadership themselves. And one of the challenges was a lack of clarity around sort of who was making which decisions at which points in time. We also were very focused on data. Relative to other countries, we saw the US struggle with data systems to not just report on COVID case rates, but really monitor supply and system capacity, whether that be staff capacity, ventilator capacity, oxygen, as we've seen be a challenge in many regions, things like that. And so that the US could actually manage nationally what the need was and deliver supply to those areas of crisis. And then the fifth area that we focused on was communication and sort of how communication occurred both between the government and the public with regard to COVID-19 and between policymakers and the delivery system itself. And as we began to do our interviews, we really saw sort of 3 critical components of the delivery system response come to the forefront. So, and this really echoes, I think, a lot of what Dylan said. First and foremost is preparation, and thinking about what sorts of upfront investments in training and planning and data systems enabled countries to respond quickly. We also heard a lot of emphasis on countries like South Korea and Singapore, where you had recent viral epidemics. They were better prepared, right? Not only did they have preparedness plans, they had patient triage plans, they conducted simulations, but they were really able to recognize what was happening and the seriousness of what was happening and what the necessary response was, I think, more quickly than the US and many other countries around the world. The second big area that we focused on was the response. And obviously this is where lots of attention has been paid. And again, one of the issues here was timing. How quickly could delivery systems address a changing and very dynamic situation? Information was changing, the threat was changing, and so we really focused in a lot on what we called sort of adaptive management approaches. So how did different countries help clarify and speed decision making in an uncertain environment? And a lot of that really came to clarifying roles and responsibilities between states and local decision makers and the federal government. That involved data systems. We saw many countries, Australia being a good example, that had more centralized data systems and dashboards that enabled consistent information for both local and federal audiences. And then, mitigating staff shortages. So for instance, in Germany, we saw very quickly that they pulled research staff out of their research institutes, which in Germany are somewhat separate from some of the direct delivery systems and pulled those clinical staff back into a clinical setting and out of research, and doing that quickly in a way that we didn't see quite so much nimbleness here in the US. And then our third big piece of analysis was really about sustainability. And this, of course, has become clear as we enter 18 months of pandemic. And as Dylan said, many countries that were doing well at the beginning have really struggled. And that is really about that ability to sustain a strong response over a long period of time. And a couple of highlights, and we can talk more about this as we go. But again, staff burnout. You know, in the United States, a lot of what we've relied on is longer hours, you know, worse staffing ratios, and just really stretching existing staff further, which has created just tremendous wear and tear on those healthcare workers as this pandemic continues. And so in other countries, we not only saw them increase staff capacity by pulling clinical and non-clinical staff from other industries, but we also saw a lot more focus on mental health support. You know, we saw a psychological first aid program that was created in Singapore, really trying to identify folks who are struggling and get them the support they needed, because we need them to stay healthy and be able to continue to work. And so we can go through additional examples. I think I'll pause there, but lots of alignment with what Dylan mentioned, and look forward to talking more about how we can take these lessons learned and continue to improve in the future.
Wonderful. Thank you, Caroline, for those opening remarks. And now I'm going to turn it over to Rebecca for her statements.
Terrific. Well, thank you, Reggie, and Dylan and Caroline, thank you so much. This very much reinforces, and I have to say, as someone playing this dual role of a physician and a vaccinator and a researcher, we see the burnout, and I'm just so pleased that this many people want to be in conversation, so really eager for a Q&A today. I also just want to thank the Commonwealth Fund and Reggie, your ongoing excellent questions to have us think through kind of what are the implications not only for COVID-19 vaccination, for example, but what is the disruption to routine vaccination, and how do we think of these lessons regarding future pandemics. So this has been, I'm going to share a bit of data that's been an incredible collaboration between my colleagues at Ariadne Labs, Boston Children's Hospital, with support from Google Health regarding some of the data sources. If anyone wants to go into the weeds of any of this, I'm eager to connect afterwards. And I'm going to try and focus on, in order to prioritize speed, equity, and scale, why our central or our first order work is about geographic access. And geographic access actually promotes convenience. And when we've seen the vaccine, for example, become convenient, we've seen those who are waiting and seeing come to get vaccinated, for example, come to begin a conversation. And when we've seen our primary care providers being able to engage in COVID-19 vaccination rollout, we see that added layer of trust and connection that's been a powerful lever for increasing equity for all. Next slide, please. And just if you need additional reasons why to talk to your communities about why vaccines are effective, just to remember that we have the data now that vaccinated individuals who become infected clear the infection more quickly. The breakthrough infections for those who are vaccinated are not only uncommon, but they tend to be milder and shorter. And third, vaccinated individuals are at decreased risk for long-haul COVID. Next slide. Okay, so I'm going to walk you through kind of a few things we've observed about the rollout of the COVID-19 vaccination. Here's a review where we saw in the plans that jurisdictions submitted that 39% of the states actually had vaccine distribution plans that referenced a health equity committee. Only 16% referenced minority group representatives, and about 51% during the time of the submission were collaborating with community-based organizations. And we know these plans have evolved over time. This is kind of an initial review. Next slide, please. Our team looked at the CDC Playbooks in the first submission, both in December, January, and then later in the spring. And what we saw was kind of this interesting pattern. First, this 2x2 shows you the jurisdictions that are using a disadvantage index. This is one of the first times we've used, for example, a social vulnerability index or an additional type of vulnerability index to think about how should I allocate a scarce resource. So those that have chosen are on the top bar there. And then the question was, are you a vulnerable jurisdiction or a lower vulnerability jurisdiction? And are you using tied barriers, which I can explain later on. And quite an interesting pattern that's evolved over time. And the question will kind of be longitudinally, should we be, in a sense, further recommending the use of vulnerability indexes when we have a scarce resource? Next slide, please. So what we've also seen, and I know many of you on this call have been following this as well, is that it's not only this, unfortunately, the planning for equity, but the planning for speed and the effect of the sluggish summer of vaccination, unfortunately, on death rates across the United States. And this has been heterogeneous. So this was a wonderful analysis done this month by colleagues where they looked at if all states had gotten vaccinated at the fastest states rate, which was Vermont, we would actually have had fewer deaths than what actually happened. And so acknowledging it's that speed, obviously, to that first dose, then folks receiving the second dose, that really prevents death at this point in the pandemic. Next slide, please. And an ongoing barrier that we've all been discussing, and I think many of you have thought of this regarding your own research and policy implications, is how we've ended up with such a decentralized data infrastructure. And as I mentioned before, tied barriers, a relatively new piece of software in the midst of the pandemic. And this is, in a sense, the complex mapping web that you're seeing at the federal side as each jurisdiction, the 64 jurisdictions, are inputting into the data lake. And unfortunately, many of these data sets are incomplete, making it quite difficult for states to understand and monitor the effects of their interventions, and then longitudinally for us to evaluate the rollout of the COVID-19 vaccine. So work ahead to improve these flows. Next slide, please. So I just want to spend a few minutes kind of thinking through, and I'll share a public tool for those of you interested, why we think geographic access is a central element to convenience. And it allows us to, in a sense, bridge to our trusted providers, for example, primary care physicians, family medicine docs, and pediatricians. And I think as we've all seen this wave from low supply to high supply, from high demand to low demand, we've obviously seen a change in distribution of the sites that are open. And we'll be continuous to see more changes, and we've been tracking this to date. Next slide. So to help you track this, if interested, we map this out week by week. It's vaccineplanner.org. This is a collaboration between Boston Children's, Ariadne Labs, data support from Google Health, where we map the vaccine deserts in your area. So we're continuously seeing, unfortunately, geographic access is not well distributed across the country. We've displayed the counties by, for example, that social vulnerability index that I talked about earlier. We shade the counties by the number of people who intend to be vaccinated but aren't. And then as the user and the planner, you can define a vaccine desert by mode of transportation. Are you trying to ensure folks can get to a vaccine by driving, walking, or public transportation? And then you can display the potential sites within the deserts. Which sites do you want to, in a sense, promote the provider to begin vaccinating individuals, or set up a mobile van, or think about vaccine education? And those are the red dots you're seeing on the slide. And you can hover over them, and Google Maps will highlight their location and contact information. You can also download the contact information for potential sites. Next slide, please. And we're continuously make iterations on the planner and eager for your input, what we should do next. Here's an example of what we built to prepare for the Pfizer vaccine, maybe a third dose, for example. And obviously, we're all waiting for the emergency use authorization for 5 to 11-year-olds, which will likely be Pfizer first. So what you see on the left is the state of Alabama when we're looking at all of the vaccines, so Moderna, Johnson & Johnson, and Pfizer. But when we look at the sites that have Pfizer only, unfortunately, the tanned color of the slide is more significant. So there's more deserts, unfortunately, in Alabama if you're trying to access a Pfizer dose. And there are more providers that are not vaccinating with Pfizer today. So this allows Alabama to think about whom to outreach to, whom to educate, and where both a mobile van or additional supply could be distributed to. Next slide, please. So I just also want to make a comment that, we've talked about evolving guidance, evolving science, and one of the things that's been striking in interfacing with primary care providers and colleagues all across the country is this information gap regarding the storage guidelines. And to remember back, this was May of 2021, that the FDA authorized the vaccine vials for Pfizer could actually be refrigerated for up to a month. And that information we have not seen get dispersed and pushed out to as many providers as we'd like to see, so that we see, in a sense, some providers saying, gosh, I can't manage the Pfizer-BioNTech vaccine because I don't have the following, for example, storage requirements. And we actually really want to counter that message that most providers can manage because it can be stored in a refrigerator for this amount of time. Here are the Moderna and Johnson & Johnson, as I think many of you know, storage requirements as such. And I'm mentioning this because we're hearing, in a sense, fear and concern regarding wastage of the Pfizer vaccine. For example, I don't want to open a vial, I won't be able to store it, for example. And while yes, there are reports of wastage, it is really a minimal amount of wastage in comparison if we think of our routine vaccination campaigns for flu or what the WHO has reported regarding other routine vaccination campaigns. So we're eager to help providers understand and those who are interested in engaging with the Pfizer-BioNTech vaccine, how they can manage it within their outpatient settings. Next slide, please. So Jess, I think both Dylan and Caroline mentioned this, that unfortunately here's kind of the visual of what Dylan mentioned, that the US in 2 days will have the lowest vaccination level of all prosperous democracies. And we have to remind ourselves we had the largest supply, and we actually had the most significant head start to any of the nations that are ahead of us. And why this has happened may be our decentralized system, the flow of information, the lack of preparation of our public health workforce, but much to discern and discuss in the second part of the hour. Next slide, please. I just want to kind of acknowledge at this point, while we think about the flow from high supply to low supply, low supply to high supply in the US, obviously, we know most countries are still facing vaccine scarcity, maybe even a vaccine famine in certain countries. And we've, in a sense, the acts of vaccine nationalism that have got us to today, if you look at Canada, Australia, for example, the United States, we've procured more doses than per capita. And as Dylan mentioned, this is not a new pattern. We saw this with H1N1, but there'll be significant work to not only move the doses, but properly procure for low and middle income countries in the weeks ahead. Last slide, please. And just kind of wanted to end in many ways that even once we sort through the supply and ensure there's sufficient supply for every nation, we think there's just significant work to help upgrade the systems, the flow of information, bolstering the supply chain, for example, preparing for this phase 1 of low supply, high demand to high supply, low demand. And there's much to be discerned from the heterogeneous nature of the US rollout. Back to you, Reggie.
Wonderful. Well, thank you so much, Rebecca, for providing that insight into the provider experience. And now I'd like to invite all panelists to turn on their video cameras and unmute. And we're going to start the Q&A portion of our dialogue here today. And so, as a reminder to the audience, you can submit your questions through the interface at any time. And thank you very much for all of you that have submitted questions thus far. But just to kick us off, I have one question that I would love everybody's take on. What role did misinformation and skepticism and distrust of science play in different countries? And are there lessons to combating this misinformation or addressing resistance to vaccines or other issues, even like climate change, that could potentially be important to take forward? I mean, you all have had that opportunity to think about how do you communicate complicated information in this environment, and we just love your perspectives on that. Anyone want to go first?
I can start.
I'll start. Oh.
All right, Caroline.
I think, I think that we did not see many other countries that we talked to had much less challenge with misinformation and skepticism. That seemed like a very sort of uniquely US problem in our research. And one of the challenges that we noticed was just the heterogeneity of the communication. So I was so struck. I mean, we spoke to a senior health official in Australia, and he said to us, my office is the single point of information for the country. We are using lots of voices to move that information forward, but we provide the messages, the data, the information out to sort of all the stakeholders, including the physicians. And he held regular webinars with any clinician who wanted to join to answer their questions, and they just stayed on the line until every question was answered. And so they invested so much in creating really compelling messages that were very consistent. And I think our sort of lack of consistent messaging created the opportunity for a lot of misinformation that sprung up ultimately.
Yeah, I am a pessimist on this question, unfortunately. I think I mentioned the example of Portugal and the success that they have had in convincing their population to get vaccinated. And some of that is, I highlight that and, their history with a military dictatorship and their relatively recent economic liberalization, because, there are just these intrinsic factors in a given country or society that have a lot of influence on how people react to, public health messaging. And, I think there is evidence, we wrote about Germany, there's evidence of these campaigns being able to communicate effectively with people, to be able to present a kind of empirical case for some of these interventions and finding a receptive audience in the population. But at the same time, I've been working on a story, actually, ironically enough, for the last week or so, talking to a lot of social psychologists about, why we do have this persistent vaccine hesitancy here in the United States that, as Caroline mentioned, seems somewhat uniquely American. And a lot of this, I think, goes back, it goes back to problems that existed long before the pandemic. Like we all know, we've all seen, the survey data on people's trust in institutions and various figures of authority. And we know that, the country has become very politically polarized, and that has a lot to do with which information sources you give credence versus which ones you tend to dismiss out of hand. And so I think if we're going to be able to more effectively communicate public health messages to people, we just need to do more to kind of rebuild people's trust in some of these institutions and some of these mainstream sources of information. Because I think until we kind of tackle that root cause, some of these more specific interventions or messages that need to be rolled out during an emergency are just going to continue to fall on deaf ears, at least for some subset of the population.
But one thing that I've found interesting kind of in the time period, that we consistently kind of survey people and ask them, well, who do you trust? And the primary care physician or a person that someone would want to speak to around their everyday care is someone who always ranks high. So Rebecca, could you just speak a little bit from your perspective and standpoint on this?
Yes, thank you. First, Dylan and Caroline, I fundamentally agree. The politicization of this moment has actually decoupled your experience as a patient asking an individual question. Is the vaccine right for me? What are the risks of my behavior? And what we see is so many patients weren't able to access their outpatient providers. And the Commonwealth Fund did a very important study kind of seeing that dip and then the resumption. But it's hard to get an appointment. Telehealth is doing a subset of this work that we need to alleviate, but we also know many Americans in particular don't have a primary care provider. And so the ability to reach out to an individual to start this conversation, is this the right vaccine for me? What does this mean for my family? Is a series of conversations that needs to happen. And we haven't thought through not only obviously where this should happen, but obviously the right reimbursement as it's happening in so many of the interstitial spaces. So I've just found that most of the vaccine sites that I work on, people come eager for the conversation. They don't want to read a post. They want to interact with an individual. They want to interact with a healthcare provider, ask their questions, get full answers. And then every person that I've interfaced with when I have a full conversation with engages and chooses to get vaccinated. And so I think it's a remnant of the isolation of the pandemic, stress of what's happened to the workforce, underemployment, those being sick at home, remote schooling, you name that cascade of stressors that folks have experienced. And so once again, we need to go back to why we need strong, robust outpatient care for folks to have longitudinal trust in providers.
Would anybody else like to add anything? Okay, wonderful. No, I think that raises a lot of important points about the experience and having that opportunity to engage and work with healthcare workers. And I think each of you have discussed the trauma that healthcare workers have faced as a part of the pandemic, whether it be burnout from constantly being on at the job, mental health supports or services. I've seen research that shows that there are many healthcare workers that have issues like transportation and food insecurity that are impacting their ability to do work. And then on top of all of that, there is a turmoil now with some of the vaccine mandates that have been placed on healthcare workers. And so I would just wonder, kind of from your various perspectives, are there any best practices to engaging the healthcare workforce and supporting them that you've seen from your experiences in your work?
I'm pleased to start just with some obvious upfront. So David Grabarski, who's a faculty member who looks at nursing homes and staffing of nursing homes, when we looked at the nursing home mandate, our first pause was this needed to be a healthcare workforce mandate, not exclusively nursing home. So the reason why is that many folks are working within many different settings, because we have, unfortunately, to have 24-hour coverage of many of these settings, we have people working per diem on a night shift, being underpaid, not receiving benefits, for example. And so first, the mandate should have been out of the gate for all of the workforce, and we should have publicly displayed for the public the percentage of the workforce that's vaccinated before you're walking into the clinic or hospital where you're being served. And second, it's about pay and benefits in many ways. We have a significant amount of part-time night workers in the United States, and that is not appropriate at this point. We need to think through what are the pay and benefits to protect the workforce doing these work. We also have an issue with visiting nurses, many of whom are sole providers. They're running their own sole business. Once again, it's a tremendous risk personally regarding their own health and their own economic status regarding the fluctuations during the pandemic. So, those are all obvious pieces, but when I talk to my friends in NHS and others, they're embedded in a very different system, and the planning was quite different. The ease of getting that first dose was significant. I think we rolled out the vaccine in many ways within health systems, hospital-based health systems first. And there is a lag between our inpatient providers, understandably, at different risks of exposure, but there's a lag before our outpatient providers who are without PPE were able to receive the vaccine.
Yeah, no, as Rebecca was talking about the nursing home staffing, I immediately popped to mind some of the research I've read just in the last 6 months about the amount of turnover that a lot of those facilities see. Sometimes it's basically like 100% turnover rate every year. And so I think, in most people's mind, including mine as a layperson, it seems like there's some dissonance between the healthcare workforce, being reluctant to get vaccinated or not feeling some of that institutional support that you were describing, Reggie. But when you remember or recall that like some of these places are seeing their staff completely turn over year over year, you realize that, these workers don't necessarily have a lot of attachment to either that specific institution or even this entire line of work, in part because maybe they feel they can't afford to, given how poor the pay and benefits can often be. And so this is another, I think we'll probably end up repeating ourselves a few times here, but this is another case where, there were these structural problems that have just been revealed by the pandemic. And so if we want a workforce that is both, more willing to buy into some of these public health interventions, but also that feels more supported. We know that pay and benefits and those kind of things can be linked to people's satisfaction with their jobs and their general mental health state. So I think this is another place where if we want to be, better able to react and have a more kind of nimble and just healthy staff in the middle of an emergency, we need to do more in non-crisis times to provide them with that support.
And I would just add, I think, the mental health piece is really hard. This is a traumatic experience to have lived through and worked through for 18 months. And I didn't see any countries where I said, wow, they did an amazing job, right? But I think there was a level of attention and care for healthcare workers that we didn't fully see in the United States. And the first is really financial. We, in a sort of largely fee-for-service environment, shut down elective and non-elective, right, non-COVID procedures. And we saw hospital systems around the country sort of immediately shift into, sort of stopgap financial loss protection mode, including cutting pay to their healthcare workers, including stopping contributing to retirement savings. And so, the sort of starting point in the U.S. was actually like a really financial hit on a lot of healthcare workers. By contrast, we saw many countries internationally, paying physicians who weren't doing elective procedures to just sort of sit tight. We saw sort of hazard pay, and then we saw other programs to really try to help protect families, including, paying for hotels for healthcare workers to keep them separate from families and not risk exposure, better childcare benefits, even sort of individual benefits as group childcare was closed during the pandemic. So, it's not an easy answer, but I think we did not nearly enough, not soon enough. So, important point.
So, I want to talk a little bit about kind of lessons and where we could potentially go from here. When you think of the successful examples of resiliency in health systems, either here in the U.S. or internationally throughout the pandemic, could you talk about what you see in those environments and what policies you believe were supporting those successes?
I would say two things. Number one, data. Data alone was not enough, but the sort of terrible data infrastructure that we started with, I think, really hampered response across so many examples, whether that be supply shortages, staffing shortages, vaccine rollout, you name it. There's been sort of endless recent literature that's come out sort of highlighting just how many hospitals weren't able to submit data electronically, couldn't participate in some of the data systems that got stood up. So that feels like an obvious must do for the US that would enable a lot better response in the future. And then the second one I said would come back to that decision-making structure. It is not that we need national federal government decision-making, but we need to clarify sort of who we want to be making which decisions and how we're communicating that, because that may need to change throughout the pandemic. And we just simply don't have any structure for thinking about, what's a hospital administrator's role in a pandemic versus a mayor's, and how are they communicating, with the White House. So I think those would be my two.
Yeah. To follow on Caroline's point, I worked on a story in the last month or so as some of U.S. hospital systems were starting to, reach capacity and having to switch to emergency standards of care. And, I think those episodes and throughout the pandemic, there's been countless examples of how the U.S. lacks a true healthcare system, even the ability to kind of stand up a coordinated system in a moment of crisis, like Caroline was referring to with some of these data and decision-making limitations. And so, I did some reporting on what had happened in other countries, and, what I found was it's not as if other countries' hospital systems were not stretched or are nearly pushed to their their capacity, but there was, a decision-making structure in place. In Canada or in the United Kingdom, there was either like a local or national government authority that was managing the flow of patients. Up in Ontario, like the local government decided, all right, we need to move 100 patients from here to here because we're starting to see a COVID surge and we're worried about running out of beds or running out of staff. Whereas, here in the United States, it's often been left to individual doctors or individual hospital executives to try to navigate those difficult situations and make those kinds of decisions. So there's certainly a debate, I think, to be had about, what those kinds of systems or decision-making processes might look like, whether we want to even have them in non-emergency times. But I think that inability to have any kind of systemic response to this crisis or an emergency like this has really been laid bare, and there are obvious examples of other countries of how you might be able to avoid those same kind of situations.
All right, great. Rebecca, I see you want to get in there, so go ahead.
Oh, I absolutely agree with Carolyn and Dylan. There's, now what do we do? And, what are the lessons of what we've already made happen? Clearly, telemedicine works for a subset of care delivery, having multi-state licensing across the United States, fixing the data lake infrastructure of the slide I showed to Caroline's point. We need to be able to have a robust set of data flows for states for this planning purposes. And we saw, state leader after state leader who had been beleaguered. And I want to just put a shout out there that it's not only the frontline provider, it's our public health officials who have been leading through this pandemic, communicating throughout this pandemic. We now do not have 40% of that technical group in those roles anymore. We have a lack of that expertise at the forefront to be communicating at this phase of the pandemic. But these are things we can fix. And obviously we've seen countries and we kind of see that mirror of when those data systems were built. But it's also the leadership capacity that should be admired, should have professional development, should be seen as experts in this realm. And obviously, this has become so much more complicated in the midst of the political and the politicization of the pandemic.
Well, I think one thing that you have all mentioned is that the U.S. underinvests in public health, as well as the other kind of related social supports that complement. And many of the countries that we have observed or places that we know do well have provided those types of supports. And so I guess the first question around this point is, do you think COVID-19 is an opportunity or a catalyst for change that can potentially open the door for new policies and practices to better support public health and the related social services for people? And if not, what do you see on the horizon? So anybody want to kick us off there?
Yeah, I have a.
Sure,
I'm
pleased to start.
Oh, please, go ahead.
All right, Rebecca first.
Pleased to start with the yes part of it, and Dylan, you can go to the full part. So one of the striking polling data that we've been following is that employers across the United States have become a trusted provider of information and on-site services. And working with several large employers to date, the rollout of the vaccine mandate has become another bridge to think about workplace wellness, workplace well-being. What does it mean to return to a better, safer, more inclusive workplace? And I suspect we'll be seeing not only more of that and more investment, but actually employees choosing to be in a workplace that thinks about wellness, thinks about flexibility if possible, thinks about your identity as a family member, as a worker within a company at all ranks. And in many ways, we think about the vaccine mandate, it has not been a stick. We have seen more people initiate or receive their second dose of the vaccine than leave a company. And actually, we've seen employees move to companies that have a significant population of their staff be vaccinated. People want to be around and at work with vaccinated colleagues. So I suspect that trend line will continue, and you're seeing a tremendous amount of virtual care being offered directly by an employer, for example, to help you navigate, to help you provide telemedicine, maybe for behavioral health, family planning, for example, as necessary. So I think that'll be a very robust avenue ahead.
Okay,
No, I'm glad you mentioned that, Rebecca, because, you know, I certainly worry about a lack of public investment and attention. So it may be that we need to be more creative and imaginative about what some of the vectors for this kind of change could be. And, you know, there certainly could be a big role for private industry, because obviously they have a lot invested in not, you know, having the kind of economic disruption that we've seen over the last 18 months. But on the public side, I still have stuck in my head conversations I had last spring with public health folks who said, you know, yeah, there'll be a momentary interest or renewed investment in public health, but, you know, as soon as dollars start to get tight again, that'll rapidly evaporate. And, you know, I don't know that folks then knew, you know, how long COVID would last or how disruptive that would be, and maybe that starts to change the calculus a little bit. But, you know, we've already seen, you know, outside experts and even the Biden White House talking about like one number to invest in pandemic preparedness going forward in Congress has at least initially come in with a much lower number. And so, you know, I am concerned that there's not going to be the kind of, you know, formal public reflection. You know, there are some people out there who are kind of putting together a COVID planning commission, kind of modeled and actually with the involvement of some of the folks who worked on the 9/11 commission, and they're kind of sitting there, you know, they're doing a lot of the preparatory work, you know, and have even described it as like, if Congress were to authorize this kind of commission, we would be, you know, we would have done a lot of the groundwork to make that possible. And so that's where some of my optimism comes from. You know, I know there's a lot of smart people who care about this, who are trying to really get these conversations jump started and some of this change affected. But, you know, just because of the nature of our political system and, you know, our inability to hold our attention on a single problem for a long amount of time, and just the general struggle over resources, you know, that is where my glass half empty pessimism comes from. So, you know, I could see it going both ways, but I think it will take a lot of work and dedication on the part of people who care about this to kind of force the powers that be and policymakers and the people who hold the purse strings to be accountable on this and to continue to focus their attention on it.
I think I'm also a bit of a skeptic on, you know, the ability for politicians in DC to stay focused on one issue in the long term. And I think also our challenge in sustaining the public response on COVID speaks to sort of the fatigue and the desire to move on. I think that what we need to do is really sort of refocus the conversation to public health more broadly. So, you know, the thing that keeps coming at us at the moment is natural disasters, right? Whether that's hurricanes or wildfires. And that is sort of at the moment a continued new threat every time we have a named storm. And you know, and a lot of the sort of data, the ability to deliver emergency response, the ability to deliver supplies, the ability to relocate folks if necessary, those are similar needs across natural disasters and COVID response. And so I think thinking about that infrastructure development for public health more broadly and not just COVID specific will really help us sort of hopefully ride the coattails of, unfortunately, whatever the latest disaster of the moment is going to be.
Yeah, I would say I end on the side of optimism because of all the different crises that we've faced and the trauma that we've experienced, whether it be from the climate emergency, COVID-19 and the pandemic itself, the social, mental health, and other kind of side effects of the pandemic. I think there's a real cry and a call for change, and I think there's an opportunity to engage around that. Well, we're quickly coming up on time here, and so I want to thank the three of you for your insights on this important topic, and thank you for sharing your ideas and thoughts with us. And audience, thank you for all the wonderful questions. We tried to amalgamate them and present them in a way that would allow us to have some great discussion. So thank you all for engaging with us there. So now please take time to complete the brief evaluation and survey. that you'll receive immediately after this broadcast ends, as well as via email today. We really appreciate you giving us insights to better inform our programming for the future. And what topics that you'd like to see us focus more on? If you want to hear more or hear this recording again, this webinar will be made available on the Alliance website. Dylan, Caroline, Rebecca, thank you all for joining us.
Thank you.
Thank you, Reggie, for moderating.